Thanks IAPH for giving the opportunity to present. And I'm very much thankful to all the participants here. And we have started the planning just 2 days before, and we have got enormous response. Uh, we are seeing like more than 200 registrations, and now we are seeing 50% of it are attending the event. It's less than 50%. So we don't know what might be the reasons why people are not attending. That is fine, but this is our small initiative to share the information and to spread the awareness on the very much important day of today, that is World Alzheimer's Day on September 21. First of all, I would like to say thank you to all the principals and all the head of the organizations who are attending this and who has spread the message. And we have emailed them just a day before, and they have spread the word like anything. Thank you so much. So without wasting time, I'm entering into the topic. Today topic is Alzheimer disease. Alzheimer disease first identified in the year of 1906 by Dr. Alois Alzheimer. The first patient is a female who is middle-aged woman. She used to visit this doctor with the problems of memory loss and disorientation. While he is discussing with this patient, he used to have extensive interviews with the patient. And then he later, while discussing with the patient, apart from the memory loss, he used to see hallucinatory behaviors of the patient just before the death of a patient. So then what he has done, as being a neuropathologist, he is a German neuropathologist. So he has done the post-mortem examination of her brain, and which revealed microscopic and macroscopic lesions, distortions, neurotic plaques, and neurofibrillary tangles in the brain. So this is the start of the Alzheimer's disease. This started in the year of 1906. So Alzheimer's is an insidious, severe, progressive cognitive impairment that is irreversible and eventually fatal. Here, it is severe disease in the later stage of life, not in the early stage of life. If it is in the early stages, it is not so much damaging to the patient. And even sometimes we cannot be able to distinguish whether this person is having the earlier stage of disease or not. And next thing is progressive cognitive impairment. Here I mean to say cognitive impairment. Cognitive is nothing but thinking. So thinking is a very complex process where the brain has to do a lot of activities. Means, for example, if I'm seeing a laptop now, I need to see the structure of the laptop. I should have the previous knowledge of the laptop, and then I should recognize the words which is in front of me, and then I should be able to comprehend the letters, and then I should be able to find the meaning of the letter, and then I should understand it, and then I have to explain to you. So these are all the process which will happen in this short span of time. So the brain plays a vital role in our thinking patterns. And if any damage to the nervous system or any damage to the structural changes of the brain, it will lead to the cognitive decline. That means our memory changes will happen progressively. And what will happen? Memory is playing a vital role for us to provide safety also. For example, if we are working in a home, like if we are cooking something, if we forget that we are cooking, it may lead to fire injury also. So memory is playing a vital role, and we should preserve our memory. So these are all the things which we are going to see in this lecture. These are the types of Alzheimer's disease. There are two types which is classified, that is familial and sporadic. Familial is having the genetic predisposition, and again it is of two types, that is early onset, which is occurring over the 30 years and less than 60 years of age, and next is late onset disease, that is occurring over 60 years of age. And one more type is sporadic, and there is no inheritance factor seen in this type of disease. Why we should know about this disease? The CDC, Center for Disease Control, estimates that approximately 1,21,500 patients with Alzheimer's disease died in the year of 2019, which is the fifth leading cause of death in adults over 65 years of age. And Alzheimer's death rate in 2023 is 37 per 1 lakh population, which is very significant. Approximately 1 million new cases are developing every year, and it is estimated that 13.8 to 16 million cases of Alzheimer disease we will be seeing in the year of 2060. Hospitalization is very common if there is comorbidities such as hypertension, congestive heart failure, osteoarthritis, diabetes, peripheral vascular disease, and COPD, thyroid disease, stroke, etc. These are all the diseases which are common in the old age after 60 years of age. Here in this presentation, I am going to focus on the how to assist patient as well as the caregivers, because when the patient is progressing to the later stages of life, he is more dependent on the family members or the caregivers. So sometimes what will happen, even the caregiver will felt stress that how much time I should care for this patient. And as he is becoming more and more attached to the caregiver or to the family member, he is becoming more dependent, and even for his minute things he is dependent on the caregiver. So that will lead to irritation in the caregiver, as well as sometimes they feel that I should stop giving care to this person. So such type of resentments are usually happen. What will happen is in Alzheimer disease, especially related to the old age, in initial stages anyone will be giving some care, etc., but after few point of time, after some point of time, they will feel that I should stop giving care to this person. So all these things are very common in our society. What is the impact again? Family members witness slow deterioration of the loved ones. So the symptoms like devastating mental, emotional, and physical changes, which result in dependence, need for care continue until death. Earlier stages, patient will wander outside. That means he will be going out and he may not be coming back to the home. That means he will be forgetting the address and he is not able to identify the space. That means spatial orientation is distorted. Means if we are going to some place and we are coming back to the some place, means we know that how should we go and in which way we should enter and in which way we should exit. But what will happen here is they will forget it. Even this is very common when they are driving. Means they will drive for a long period of time. They will go to some place and they will see that they don't know now where they are going. They will just keep driving. So that will happen and they will get lost. So this is very common in late stage of disease. And as we discussed already, they need maximum assistance with the activities of daily living. And sometimes there may be role reversals if there is a Alzheimer disease has developed. Means parent has become a child and child has become a parent. Means in the time child should get care from the parent, the child has to give care to the parent. So that times that too happen. And next thing is support will decrease as the situation continues over the years. The physiology of the disease is, before going into the physiology, let us have some basic introduction of the anatomies of brain. In the brain, there is a cerebral hemisphere which is dividing the cerebrum into two hemispheres. And again, these are divided into four lobes: frontal, parietal, temporal, and occipital lobe. And in this frontal lobe is related with the voluntary motor activity, higher intellectual functions such as planning, judgment, decision making, and problem solving. So if we are planning something, if we are able to do take some decisions, or if we are able to solve our problem, that is the activity of the frontal lobe. If there is any changes, if there is any lesion in the frontal lobe, we will be seeing the symptoms of impulsiveness, hyperactivity. Why there is impulsiveness? Means if I know that if this is a mobile and I know that I should know how to use it, but I am not able to use it just because my brain is not accepting and he is not telling me how to operate this mobile. I know everything about it, so this is causing irritativeness among me, and then I will get the impulsiveness. And sometimes I may even get over irritated to cover up my deficiencies in front of everyone. So such type of things very common in the Alzheimer disease. Next thing is Broca's area, which is covering the verbal language skills. Why this area is important is they may be having all the vocabulary in their mind, but they are not able to pronounce it, or they are not able to get the right word to speak. And in later stages of disease, they are not even able to comprehend the sentences. They will be just blabbering something. So these are all the things which we'll see in the disease. Next thing is parietal lobe. Parietal lobe process the sensory input information related to taste, position, sense, touch, shape, and consistency of objects. That means if we are able to take a brush and hold it, then we are able to identify it as a brush just because we are having some of the previous memory and we have some learning that this shape is called as a brush and this can be used for mouthwash. And what will happen if there is a memory loss? They will be having agnosia. Agnosia means they will not be able to identify the objects. So this type of symptoms are very common in the Alzheimer's disease. Next is Wernicke's area, that is comprehension of written and verbal language. So they may be reading and they are not able to understand, or sometimes they are not able to speak. So these are all the problems related to left temporal lobe of the brain. So temporal lobe again is very much important in the auditory receptive areas. Impaired memory for verbal material is linked to damage of left temporal lobe and inability to remember non-verbal material, that is faces associated with the damage to right temporal lobe. That means if there is a damage to the right temporal lobe, even if a family member is in front of us, we are not able to identify who is there. That happens in the very later stages of the disease. And if it is in the earlier stage of the disease, they may be able to identify themselves or they are able to identify the near and dear ones, but they are not able to identify other ones. So in earlier stages, they are able to distinguish person to person, but in later stages, they are not able to distinguish person to person also. So these are the symptoms which we'll see. Next thing is, based on the category brain deterioration, we are dividing the Alzheimer's into two types, that is cortical and subcortical. In the cortical type, we are seeing the memory disturbances, but in subcortical type, we are also seeing the motor disabilities. So next is hippocampus, amygdala. These are the part of limbic system which are very responsible for the memory. Next is hippocampus is responsible for acquisition, temporary storage of declarative memory. That means root memory. As we have seen that I have told already, they are not able to remember the route. So how they should come back to their home? That means they are forgetting, especially during the evening times, which is called as sundowning syndrome in the Alzheimer disease. So here, if there is a any lesions which are in the hippocampus, then this type of symptoms will happen. And apart from this, amygdala is controlling the endocrine metabolisms and also motor activities, etc. Apart from this, sexual emotional aspects are also controlled by amygdala. So if any symptoms related to lack of apathy, lack of interest, that is apathy, which can be attributed to the lesions in amygdala. Next is these are all the diseases, Parkinson disease, Huntington disease. These are also examples of dementias. And the as of now, we have understood that there are the problems with memory and also there is a problem with the activities. So if there is a problem with activity, he may need dependence. Initially, they may need a very light dependence, or in the progressive stages, they may need a complete dependence. And next thing is neurotransmitters. Neurotransmitters play a vital role, especially dopamine, which is having the effect on the movement, learning, emotion, abnormalities in the concentration, and this will again lead to Parkinson disease. So here, why dopamine is important is the medications which are being developed should cross the blood-brain barrier. In the Parkinson disease, we may be using the levodopa and carbidopa. That medication can cross the blood-brain barrier and that can affect the treatment course. But in this Alzheimer disease, many of the researchers are still working out to treat the disease. But they are trying to find innovations in the pharmacological aspects, but still it is not been successful. So Alzheimer disease is not having a perfect cure as of now, but they are giving symptomatic treatment, or they are just having some prognosis. They are having some of the predictions based on which they are treating the disease. Next thing is dysfunction. This may be related to the nicotinic acetylcholine receptor, that is NR. This again very common in the cognitive and neurodegenerative diseases. So damage to hippocampus, cerebral cortex will lead to memory loss and impaired cognition. Disrupted neuronal communications will lead to trembling, etc. Next is cellular metabolism will decline, especially in vascular dementias. So you may be seeing if there is a decreased blood flow to the certain part of brain, there is some hypoxia, and again associated symptoms will develop. And the neurons have the capacity to stay for at least 100 years of life. But if any damage happens to neuron, they cannot be regenerated. But still, there are some researches going on whether these neurons can be regenerated. Next thing is presence of neurofibrillary tangles and amyloid plaques is a significant characteristics of the Alzheimer disease, and it has been evidenced by amyloid and tau proteins, which are uh, involved in the formation of abnormal structures like neurofibrillary tangles and amyloid plaques in the brain. So more advanced Alzheimer disease, in this disease, we are seeing the decreased activity of enzyme choline acetyltransferase in the brain. So we are focusing on the replacement of this enzyme so that there is a production of acetylcholine and significant drop in the acetylcholine linked to adverse cognitive and neurodegenerative effects. Aging is very common. Brain cells are vulnerable to oxidative stress. So because of aging, there are memory losses. But if it is very drastic, then it is considered as Alzheimer's. So if above 60 years they are having the symptoms, that is very common. But if it is affecting their activities of daily living, then we consider it as Alzheimer disease. So research shows that vascular risk factors in the midlife we should focus. That is, if we are able to prevent hypertension or if we are able to prevent the vascular diseases in the midlife, then we are able to decrease the incidence of Alzheimer's in the later age of life. That is what is important. So management of hypertension plays a vital role in maintaining the brain health. And next thing is there are some of the metabolic studies which happened on the mice, and they found that women are more prone to get Alzheimer disease as compared to the men because of the physiological changes happen in the women around the perimenopausal stages. Next thing is preclinical phase of Alzheimer disease is early in female aging process, coincides with the transition of perimenopause, that is leading to more chances of that is the reason we should focus on the health of perimenopause so that we can delay the onset of Alzheimer disease. So there are some other comorbid factors like herpes simplex virus infections. Apart from this, we see diseases such as hypertension, COPD, and any other neurological disorders which are very common in the old days. And these are the modifiable risk factors: head trauma and hypertension. If we are able to do good exercise in the midlife, we are able to we have some less risk of getting cardiovascular diseases, especially hypertension. And we should be able to avoid the traumas like avoiding the accidents and safe driving, etc. This will help in reducing the modifiable risk factors of Alzheimer disease. And next thing is aluminum. This is related to chronic toxicity of brain, and sometimes it has been found in the researches that the tap water, if it is having the composition of aluminum and silicon, and it will be leading to the Alzheimer disease. And it may not be attributed to the aluminum vessels which we use for cooking, but still researches are ongoing on the topic. And apart from this, pesticides, general air pollutants, lead, other toxins are linked to Alzheimer disease. So we should be taking proactive steps. So that is the reason nowadays the market of organic foods are growing up like anything. So everyone wants organic foods. They want organic things. So means it is nothing but we have to avoid pesticides so that it will have some good effects on the health of brain. And apart from this, supplementation of B12 and B6 has been found significant in the protective effect in some studies, and some studies has proven that it doesn't have any effect. So what we do is we will send the lab analysis. While taking the blood sample, we will assess the B12, B6 and folate so that we can give supplementation to the patient. Next thing is neuroprotective effects of exercise. I have already discussed this. If we are able to do exercise, we are able to reduction of cardiovascular diseases and also ultimately reducing the cognitive impairment in the later stages of life. So memory deficits will lead to loss of memory, unable to recognize themselves and the family members, and it will complicate the ADL. This I have discussed already, how it is different from the normal aging and the Alzheimer disease. For example, I will say that temporarily forgetting someone's name is very common. Even we forget it every day. But if you are not able to remember even after some point of time, means if we are seeing a person on a road after 5 years, we know that person, we don't remember the name of that person, and we try to recollect the name, but after some point of time we are not able to recollect. But after some point of time, when while we are going back to the home, then we realize that yes, he is my sir, his name is Nemal Reddy or something like that. So that will happen in normal stages. But in Alzheimer disease, however you think, you are not able to recollect the name. It is just because of the underlying pathophysiology which we discussed earlier. So if it is forgetting and if you are recollecting, that is very normal. But if you are completely forgetting and it is affecting our normal life, that is, we are forgetting our address and we are just roaming on the roads and we are not able to identify where we are not able to tell our family members address, or we are not able to tell anything, then it is possibly Alzheimer's disease. So early stages, these are the terminology which I would like to introduce. Amnesia is memory impairment. Aphasia is language impairment. Agnosia is inability to identify common objects. Apraxia is inability to use objects. So these are all things which I have explained just before. Amnesia is we are forgetting the things. Aphasia, language impairments, means I know that I want to speak something, but I'm not able to speak that because of I'm not able to comprehend the language, or I don't have the vocabulary, or even there is vocabulary in my mind, but I'm not able to pronounce it properly. So these are all the things which will happen. Next is agnosia. That means if I am seeing a mobile, I know that it is a mobile, or sometimes I am not able to identify it is a mobile, or I don't know how to use it. So that will happen in these things. Apraxia is inability to use the objects. That is apraxia. Agnosia is inability to identify. Apraxia is inability to use. That is the difference between the agnosia and apraxia. Apathy is loss of interest to the surroundings. Now we are going into the stages of Alzheimer disease. In the stage 1, which is preclinical stage, this is very normal. There is no memory problems, no need for any lab test. There is no changes in the lab test, and there is no diagnostic criteria. Now, if there is no diagnostic criteria, there is no biomarker changes. Why it is there? It is there just because the disease researches are ongoing. In future, if they are able to identify some of the biomarkers, then they consider this as a preclinical stage. Next thing is stage 2. Stage 2 is very mild cognitive decline. Very mild cognitive decline means we are forgetting the familiar words, names, locations. Sometimes we keep the keys and forget, and sometimes we forget eyeglasses, etc. So these are all very common. This is not evident on the medical examination. Even by daily interviewing with the patient, we are not able to identify such type of things. Only the patient knows these things. But even sometimes the relative may not be identifying these things. So this is the stage 2. Next thing is stage 3. Stage 3, that is very mild cognitive decline. Here, on the medical interview or clinical testing, that will reveal the problems with memory or concentration. So we will be asking them to recollect the things, and we will testing the recent memory, immediate memory, and past memory, or remote memory. Then we are able to identify that there are changes in this memory, and then concentration levels also. What are name finding problems? We will ask them to see this word and tell the meaning of it. They are not able to tell even the general things. So in very mild cognitive decline. And next thing is inability to remember names when introduced to new people. Again, this is very common with us also, but after some point of time we can remember. But with some verbal cues, with some memory cues, like if a person is saying Ram, if I'm correlating with the Lord Rama, then I can remember his name very easily. So that's how we improve our memory. But they doesn't have such type of capacities also to remember the other names of persons. That is what we will see. And next thing is performance issues are very common at the workplace, which is very noticeable by others. In in the second stage, we have seen that they are not able to do the things they know themselves, but others are not able to identify. But in this stage, this is the difference. We are others are able to identify that there is a decreased performance level of this person, and they will keep some of the object in some place and they will forget it. This happens very often, and they are unable to plan or organize the activities. This type of things again we see in the early stage of, that is very mild cognitive decline, or stage 3 of disease. Next is stage 4. This is early stage moderate cognitive decline due to mild or early stage Alzheimer disease. Here we will see clear-cut deficiency in the following areas like reduced memory of personal history. Now they are, see here, they are forgetting their own history. Till now we are asking only about the surroundings. Now they are forgetting about themselves. That is the stage 4 characteristic. Decreased ability to remember the recent events, impaired ability to perform challenging arithmetic solutions. Like we ask patients to subtract 7, serial 7 from 100, so they are not able to do that such a complex task. That is in the stage 4. But if you ask them to subtract 4 from the 100, they may be able to do. So that means they are able to do less challenging arithmetics, but they are not able to do more challenging arithmetics in the stage 4. Decreased capacity to perform complex tasks, especially shopping. Shopping needs, like we have to go out, we have to find the road, we have to find the address, we have to pay the bill, and we have to collect the item, we have to identify the item, and then we have to check it, and we have to come back to the home. So these are all the activities are happening. So this, if any activity is involving such type of series of events to be done, then it is called considered as a complex task. So in this early stage, they are having very difficult with the complex aspects. So our focus should be on giving them simple tasks so that they will have some sense of self-satisfaction, so that they can improve on self-care. And sometimes because of such things, they are withdrawn from the society, and they will not be able to attending the functions also. Next thing is stage 5, that is middle stage. This is moderate or mid stage of Alzheimer disease. Here we see major gaps in the memory and deficits in the cognitive function, and they may need assistance in the daily living. They may need minimal assistance. In the earlier stage, they can do by themselves, but here in the stage 5, they may need the minimal assistance. They are not able to recall the important details such as mobile number, address, school, etc. And they are confused about whereabouts. They don't know where they are staying now. They are having wandering habits in the evening, or sometimes they go out and they are not able to recollect their address. So such type of things happen in the stage 5. And they are having trouble with less challenging arithmetic. In the previous stage we have seen that they are having problem with the more challenging arithmetic, but here they are having the less challenging arithmetic. Even they are not able to deduct 4 from 40 also. So such type of things we'll see. So if they are not able to do the counting, and we cannot even expect the complex activities like shopping, means if they are giving some money and they are not able to get back the desired amount, they are not able to cross check also. So next thing is need to help choose clothing as per the season or occasion. We should be giving suggestion, or we should be able to assess to the person. The caregiver has to tell to the person. And here we can see that they may be written the names of own spouse and children. Means they are able to remember their name, their spouse and children, and they doesn't usually require any assistance with eating or toilet in this stage of disease. And next thing is stage 6, that is middle stage, severe cognitive decline, moderate is severe or mid stage Alzheimer disease. Here they are having the memory difficulties, which is worsened, noticeable personality changes also seen, and they may need extensive help in the activities of daily living. They lose most awareness of recent experiences, events, and surroundings, and they recollect imperfect personal history. They know their name, but they are not able to tell their history also. Even their personal history, they are going to forget in this stage. So again, they may forget the name of spouse or child, help needed for dressing, disturbed sleep wake cycle. They may be getting up any point of time, and they may need help with the toileting and dressing also. And here they may be facing the most advanced symptoms of psychosis, such as suspiciousness, delusions, hallucinations, and sometimes compulsive behaviors to cover up the disease, etc. And they tend to wander and become lost. This is very common in the stage 6 disease. And the last stage is the late stage of the disease. They are not able to speak the words. This is the final stage of the disease. They lose the ability to respond to environment. They lose ability to control movements. They lose capacity for recognizable speech, although words or phrases may occasionally be uttered. They may need help with the activities of daily living like eating, toileting. They lose ability to walk without assistance. Means if they want to walk, they need with the help of aids, they are only able to walk, or they are able to sit without support. They are not able to sit without support. They need assistance to sit also, or they are not able to smile. They are not able to give the facial expressions, or sometimes they may not be even holding their head up also. And next thing is abnormal reflexes, muscles become rigid, and swallowing is impaired in the late stage of disease. uh, I'm not going in detail about this because we are having some limited point of time. While I just give a glimpse of it, but differential diagnosis with delirium and depression is very much important in while diagnosing the Alzheimer disease, because delirium is a for a short span period of time, but dementia is a cognitive decline that is over a progressive point of time. That again we'll see. So these are the DSM-5 criteria. Evidence of significant cognitive decline, like they are not able to do the complex activities, they are not having the attention, they are not able to recollect the things, there is having problems with the language, perceptual, motor, social cognition based on this. And again, this information the patient they themselves may say on the clinical examination, or there should be a knowledgeable informant. That means the relative should be able to tell that this is the information. If there is no relative is available, at least they should have the previous clinician documented evidence to identify that there is a decline in the cognitive activity. And next thing is, apart from this, they may need a neuropsychological testing to see that if there is any impairment in the memory and activities of daily living. So again, dementia is not diagnosed if the patient is experiencing the delirium. Delirium is a condition. They will be having temporary loss of memory, especially during hospitalization, just because they are not able to expose to the sunlight, or they are not able to orient to the time, place, and person. So because of this, they may be experiencing the same type of symptoms as like a dementia, but they can be recovered easily. But dementia cannot be recovered. As we have seen already, dementia has no cure. Only thing is we are giving supportive treatment in the dementia. So diagnostic evaluations focus on the history of patient, the medications of patient. Some medications also affect the cognition. Alcoholic assessment, nutritional status. If patient is not able to take care of himself, if he is not able to take enough nutrition, then he may be facing the problems of weight loss, etc. So in the middle stage of disease, they may need extra calories also. So that I am going to discuss in the next slides. So next thing is functional assessment is needed. If they are not able to manage their routine activities, they may need to refer to the rehabilitation, and they may be giving training that how to simplify the activities and how to do the things, how they can do the problem solving in the day-to-day activities. Financial ability, they are not able to pay checks, balance accounts. If we are giving them their passbook also, bank passbook statement, then they are not able to tally what is right and what is wrong. Next thing is mobility. If they are, we have to assess whether they are able to drive or they are able to use the public transportation, and we should plan the care accordingly. And family occasions, social gatherings are avoided by patients in later stages of life, later stages of disease, not in the initial stage of diseases. And we should focus on the recreational activities of the patient, so that to divert to divert the patient from the sufferings. So these are all the things which again we see: speech, sensation, coordination, muscle strength, eye movement, reflexes. And again we are doing the lab test apart in normal routine test along with B12 folate levels. And why we should do this thing, I have already explained with the research evidences. And CSF testing is done to see is there any infections. Again, mental status examination, neuropsychological testing, and CT scan is done to see is there any infarct or lacuna or neurofibrillary tangles or in tau protein, or if there is any changes in the shape of brain or size of the brain, etc. And next thing is SPECT, that is single photon emission photography, computed tomography. This is again a CT scan type. They are seeing the cerebral function assessment and also seeing the cerebral blood flow. So again, cognitive impairment in at least two of the following domains: ability to acquire and remember new information, reasoning and handling complex tasks, language fluctuations, personality changes, clear-cut history of worsening, prominent cognitive deficits, absence of neurological disorders, and use of medications that impact cognition. If we are able to rule out at least two symptoms in this, then it can be considered as an Alzheimer's. So our focus is on the safety of a patient. We should better avoid the restraint, whether it is a physical restraint or maybe a chemical restraint, because this is the most common for the legal issues in the hospital. So better to get avoid the legal issues which is having no use for the patient and also for us, which will create a lot of financial wastage and also the time wastage for us and to the patient also. Next thing is reduce the risk of trauma and injury related to the poisoning. You keep the safe custody of any sharp objects, and if there is any corrosive chemicals like phenyl, etc. in the home, keep under the lock so that the patient will not ingest. They are not able to identify. That is what we have discussed in the earlier stage. And reduce the falls, avoid the fractures, and reduce the wander behaviors. Now everyone doesn't like to stay in a closed environment, so you should be able to provide a protected environment where they will not be going out the compound, but they are having some open space to roam around, or you should be accompanying the person if they want to go outside, or you may need some assistance to them so that they will not get lost, or you maybe use some tracking devices which we are using nowadays. So these things will happen. Next thing is meeting the needs. As we have seen, they may need help with clothing, eating, going to toilet, etc. And they need multidisciplinary time effort. They may need rehabilitation, and we know that there is no treatment to cure, and care can be planned as per the identified behaviors. And there are pharmacological agents to support like cholinesterase inhibitors, memantine, NMDA receptor antagonist, and sometimes they may use antipsychotics and antidepressants. It may be occasionally necessary if they are experiencing the hallucinations, but it will again increase the side effects, so it is not preferable. Sometimes it is necessary and sometimes it is not preferable. So these are all the pharmacological therapies available: donepezil, rivastigmine, galantamine. So, and these are the cholinesterase enzyme inhibitors which are approved by the FDA. Tacran is a first approved drug which is having lot of side effects, and now it is not available because of the side effects. And in 2023, FDA has approved a new drug, that is lecanemab, which is having which it is like anti-amyloid monoclonal antibody given intravenously over 2 weeks. And non-pharmacological therapies include recognize and accept the reality. Yes, this is what happens with everyone, and we should accept the reality and we should provide the support. And also we should educate the family members to give appropriate care to the patient. So that is what nurturing the relationships between the patient and the caregiver and the family members. Support support and comfort measures, dignity preservation and improving the quality of life, and preventing complications like incontinence, pressure ulcers, and middle stage of Alzheimer disease. This is what I mean to say. They need 600 more calories to prevent weight loss. So we should focus on the nutrition in the middle stages of the Alzheimer disease. Apart from the normal requirement, they need additional 600 more calories. Simplify the task if possible. Now you have understood what is a complex task and what is a simple task, and if possible, try to simplify the task. Next is promote the positive behaviors and encourage the self-care. And last point is shadowing behavior. This is the cause of caregiver burnout. Means for every small task, the patient is asking you to help. Even to take a brush, he may ask you, give me the brush, or he may not even tell also. So you have to go and give to them. Or else wherever you go, he may be following you. He may be asking you a lot of questions. He may be irritating you. So at one point of time, you may get irritated and you feel that I should not take care of this patient. That is called as burnout. So we should focus on the caregiver burnout also. That means we should encourage the family members how they should deal with such situations, how they can divert themselves, how they can improve their coping mechanisms to deal with such patients. These are all the things we are going to teach to the family members. So these are the final things which I want to tell. Evaluate the medications, evaluate the bed timing of patient, encourage exercise in the middle life, avoid caffeine and alcohol during sleep times, focus on art therapy, diversion therapy, and manage aggression of the patient, and provide safety to the patient. So dementia is a chronic, slowly progressive disorder of failing memory, cognitive impairment, and behavioral abnormalities and personality changes occur after the age of 60 years. And there are different types of dementias which I have not discussed here, and I will share in the further classes or in my YouTube channel. And these are all the subjective data. Subjective means what patient says. They say that they are not able to recollect and they will be wandering. They are not able to do the activities of daily living like shopping. They are not able to identify the objects, loss of interest, changes in the mood, etc. And in objective also we are able to see there is memory impairment, impairment in the social and occupational functioning, and impaired ADL, and profound personality changes, and they may be experiencing hallucinations in the later stage, and there is a severe deterioration of cognitive function. So management is focusing on the self and application of behavioral interventions, and healthy brain promotion needs blood pressure management, especially doing exercise in the middle life will prevent uh, cardiac diseases and ultimately prevent Alzheimer disease in the later stage as per the research studies. Increased physical activity is very much important, and cognitive training is very much important. So behavioral change interventions focus on cognitive behavior therapy, motivational interviewing, positive psychology, and behavior modifications. Blood pressure management include medications, reduce sodium in the salt, increase physical activity, quit smoking, and plan for self-monitoring. So primary goal of end-stage Alzheimer disease is prevent complications, ensure safety to the patient. Music, hand massage, quiet talking, olfactory stimulation, sensory activities will help. And reality orientation to the time, place, and person will help them to orient to the present time and place and person. And indulge in the recollection of past events. Means if patient is able to recollect his personal history, if they are having some of the enjoyable moments in their life, you ask them to recollect, and so that they can divert from the present crisis in their life. So these are all the references from which I have taken. With this, I am going to end my presentation. Thank you so much. Over to Melvin, sir.
Thank you, sir. Thank you for your detailed explanation on Alzheimer's disease. And I hope it's really helpful for the participants to understand more about Alzheimer's disease. Now the floor is open. I'll give the access to all your mics. The participants, please, you can unmute yourself. If you have any doubt, we can have a discussion. If you wanted to give feedback about the session, you can welcome any improvement needed for further anything you can talk. We have given access to your mics. Participants can unmute yourself and talk. If you have any queries, please.
Hello.
Yes, ma'am. Yes, ma'am.
I'm working as a Vice Principal in Sri Ramachandra Faculty of Nursing, Srigar, Chennai, Tamil Nadu. It's really is an interesting topic. Sir, I got two queries. How we can prevent the Alzheimer's in the earlier stage? One, what is the modalities to prevent further?
Thank you for the question. I have discussed already in this presentation that focusing on the exercise in the mid stage of life, that is the first aspect which I have considered. And next thing is promoting
modality. For example, we knew that reading the books that need to be updated, and then they can keep their cognitive status in a stable mode. That will help them to have their recalling the past events, the memorable events can be, that will also improve that cognition. Many more is available for to prevent Alzheimer's in the early stage. Sir, am I audible?
Yes, ma'am, you are audible. Actually, I'm not able to answer you as I am not aware of the topic. I can email later by doing some research on the topic. And what I have presented today is the work of last 2 days, which I am doing on the topic. And if queries is there, can you please email so that I can respond to you positively?
Yep. Thank you so much for your response.
Yes, thank you.
Any more?
Sir, Melvin, sir.
Yeah.
we can have the queries by email so that I can answer them in an appropriate manner, because the topic still now I have presented is of very limited. I know that,
Yeah, yeah.
and still
Uh,
there is a
uh,
lot of things which we should know about the
yeah,
topic, and I
yeah,
will
yeah, yeah.
be telling them in the sooner or in the
Sure,
later
sure.
presentations.
Okay, dear participant, due to the time constriction, because we have scheduled this meeting for an hour, now it's already 11 o'clock. Any furthermore queries, we are available through the email. Anytime you can contact us through the email. We are ready to answer, and even the research discussion or furthermore research needed on
Hello,
this,
sir.
we, we are ready to do. Yes, sir.
Yes, sir.
Uh, Sir, I want to ask one question.
Yeah.
Mhm.
Sir, means which all activities are used to cure this? Means in rehabilitation.
Sir, rehabilitation, we are saying that they have to focus on the activities of daily living. Means like, if they are not able to identify the address, means how they can identify, means how we can assist them with the aids, or if they are not able to recollect the things, then how they can improve the things. Means I have told that if there is a complex activity, we have to make it a simple activity. Means like, I said very clearly that if I am talking to you, means I have some of the background work which is having complex activity. It is a series of steps. So what they do is, in rehabilitation they will try to simplify the aspect. Means they will find out which is the easiest possible way and how the patient can do that. That is what in rehabilitation they do.
Okay, thank you, sir.
Yes, sir. Thank you.
Thank you, sir. Dear participants, and we appreciate all your patience in participating and listening to the lecture. The scientific contents tend to change every day. It needs a lot of research and at the end we can come up with evidence-based practice. As time is restricted now, and we can have the healthy discussion through the email. You can post if you have any queries to the email, and we are thankful to the IAPH and World Explorer YouTube channel to create this awareness, because these need to be talked among us. First of all, we have to understand what Alzheimer's, and because we met off from a many different field, like different field in the sense different departments like community, medical, surgical, but however it's a common problem of every public, and we have to get oriented and recall our memories about these contents. So I hope this particular webinar helped us to connect each other across the country and
Sir,
recall, learn a
shall I
lot about.
interrupt you if you don't mind?
Yeah, of course.
Here we are having very distinguished participants. If they are able to add something to the topic which is very valuable to the participants, they can speak up, and uh, uh, that will be a good thing. There are many distinguished persons are in the participants. If they want to speak, you can allow them to speak for 1 or 2 minutes.
Hello, am I audible?
Yes, sir. Yes,
Yes,
sir.
sir.
Sir, please, sir.
Hi, good
Santosh,
morning.
please.
Sorry, I am not a distinguished speaker, a person. Just I want to uh, share my experiences from Germany here. My name is Santosh. I also belongs to one of the member of IAPH. So I currently work in Germany. So it's Alzheimer's disease and dementia, such kind of uh, disorders are very predominant here, and they're diagnosed at the early stages, like 50 year at the age of 50s and 40s. And there are many questions like what could be done for the prevention? How uh, the one thing which I have seen in the practices of among the German doctors, German psychiatrists, or let me say psychologists, is that uh, they have an entirely different health system where the family doctor is concerned and noted the regular changes in the person. If any changes are there related to short-term memory or behavioral changes, that will be notified at the early age, and they start therapy from the day one. So that is one kind of one. Second, there was question what kind of rehabilitation or what to be done as a preventive. It all depends upon the patient's ability to do his daily activities. What is his deficit in his self agency? Depend upon his self agency deficit, they plan the activities. Predominantly, as Mallikarjun said, it will be related to his daily activities, which hampers him most of the time. And because of his forgetfulness and not having able to do his activity, he'll be more stressful. He'll go and again under depression, again more issues with him. Henceforth, generally we can say many things what could be done early detection, early prevention as theoretically, but practically it has a lot of other implications. It is entirely different. So with this, I once again thank Mallikarjun for giving us a good lecture for around 45 minutes to 50 minutes, and I also personally say uh, wish him a happy birthday on his birthday. He started this work. Thanks, Malli, and thanks Melvin for organizing it. Over to
Thank
you.
you, sir.
Thank you, sir. Thank you so much for your presence here. And with your busy schedule, you attended this. Thank you so much, sir, for giving us this opportunity and this platform to conduct on behalf of IAPH. Thank you so much, sir. And all the participants, we had a nice time and we had a nice learning today. As sir mentioned, today is our speaker's birthday. We wish him a very happy and healthy birthday on today. And thank you so much, sir. Thank you all the participants. And somebody asked when we'll get the certificate. Definitely by today evening, you all receive your participation certificate along with the record. Thank you so much.